First of all, thank you very much for all the participants that are connected with us in the webinar. Thank you very much also for the Professor Asbjørn to be here with us for this webinar about opium tincture and the therapeutic innovation around the severe diarrhea. Okay. Just to pass a quick information how is the webinar would go. Okay, so Professor will present us his presentation during approximately 1 hour. During the presentation, all the attendees that intend to make any question are allowed to do. They can do the questions either using the micro or in the chat that is open to everybody. Okay. Professor Asbjørn has also some breaks during the presentation in case it is necessary to make additional questions. And in the end of the presentation, we will open the discussion to everybody. In order to be more interactive, we hope that the participants can also make some questions or some comments about all the facts and all the subjects that we'll be discussing during the webinar. Okay, so in order to not lose more time, I will pass the floor to Professor Asbjørn.
Thank you very much for inviting me to give this talk. I'll just change my slides a bit so I can see everything. And this talk is about opioids and their effects on the gut. Let's just a second. Yeah, just to give a short presentation of myself. I'm a professor of gastroenterology, and I'm heading a research group comprising 25 people. That is about 10 different disciplines, and I'm not going to show you what we're doing. There are many areas, as you can see, but the blue ones are those that are interesting from this perspective. We're doing a lot of studies in motility. This is the autonomic nervous system, but also imaging, pharmacology, and also clinical studies. And we have done that for the last 25 years. This is a team, how it looks like in the fall in Denmark. What it characterizes our research team is that we have what we call the full Monty. That is, we do basic research. We also do translational research in healthy volunteers. This is what I'm going to show you today, mainly, but we also do clinical studies. And finally, we use this knowledge to establish a lot of guidelines. We have been, the last 3 years, we have published 4 international guidelines in motility, pain, and the use of opioids. Especially within pharmacological studies, we do everything. We have experimental studies, very basic with kinetics, absorption, and sensory testing. We also have in silico studies, and we do, as I said, many clinical studies. We have a lot of collaborations, and these are all very active collaborations where researchers around the world use our equipment. I believe at the moment we have about 40 different collaborations, and we use a lot of time to visit these countries, especially after the pandemic, and also to set up new studies, among them in opioids and motility. So this is just to make a little break to show you, and now we go to the real agenda. And first of all, coming back to opioids, this is not a new drug, as you know. It has been used for many thousand years as sleep medicine, but the first time it was used for description of pain is back in 1500 before Christ, in the Egyptian papyrus, where there was recommended to treat headache. So opioids have been used for many years as sleep medication. That is actually why morphine was named after the Greek god Morpheus, and also as pain medicine. But we don't know how long it has been used for motility disorders, but at least for about 200 years. when people speak about opiates, they very often tend to focus on opiates' effects on the central nervous system and therefore on pain. But you should be aware that the enteric nervous system has as many neurons as the brain, which is about 5 billion, and it has a very complex organization with communication, library, information, everything. And most of the neurons are localized in the myenteric plexus, where they control motility, but also in the submucosal plexus, where they are responsible for water flux. And finally, opiates also interfere with sphincter function, and I'll come back to that. But it's very important to know that when you give opiates, it's not only about changes, slowing down motility, it's also changes in motility and, in secretion and in sphincter function. So again, normal propulsive movements changes during opiate therapy to very disorganized motility patterns, and especially also retrograde motility resulting in nausea and vomiting. They also interfere with a very sensitive system, very controlled system of water transport, and finally they have an effect on the sphincters, as I said, where they contract the sphincters. So in other words, motility, fluid absorption, secretion, and sphincter tone, that is the effects of opiates on the gut. So now, moving into motility, it is not as simple as we thought, because there seems to be differences in the way opiates interfere with motility in the different segments of the gut. And what we know is mainly from animal studies, where they have been able to characterize the different opioid receptors in the gut system, as I said, in the submucosal plexus and the myenteric plexus. There are also opioid receptors in different other cells, but most cells with opioid receptors belongs to the enteric nervous system. So now, what we know within motility, as I showed you before, when we give opiates, we change motility, we increase the tone of the gut, and we decrease the motility in total. And when you give opiates, it results in uncoordinated muscle activity. And this is what we use in diarrhea, because in diarrhea, motility is not normal. It's abnormal, but it's mainly very fast, and that is why they have diarrhea. But when you give opiates, you change the tone, and you also decrease the speed of this motility pattern, and this is why they have an effect on diarrhea. One thing is that, as I said, there are segmental differences in the way the opioids work, because we have opioid receptors from the mouth to the anus, all over the gastrointestinal tract. But if you look at this, this is again an animal experiment. When you give opiates, you can see that they change the tone from the jejunum and downstream, but especially you can see the changes are present in the colon and especially in the rectum. And there is also a dose-response relationship, because the more morphine you give, the more they interfere with the motility pattern, especially again in the rectum. And finally, if you give an antagonist like naloxone, this is given here, so here you have the normal motility, then you give morphine and you see an increase in motility or in tone. We don't know here because it's a segment, but we see an increase in tone and motility, and then with the open arrow, which you hardly can't see, you can see it totally abolish the changes you see from opiates. So it is an opioid effect, and it changes from segment to segment, and correspondingly we also know, if you look into the mu opioid receptor expression, it is mainly present in the colon and rectum, and this is then how we know it is in mice. But I'll come back to the human situation. I'll not use much time on preclinical research findings. But one thing you all know is that when you give opioid, you see tolerance. That means if you have an effect on pain, it vanishes over time. the more you give the opioid, especially if you give it intravenously, the more tolerance you see. But this is not the case when you give opiates in the gut or to the gut. And we know that, for example, from at least the colon, and I'll not come into the biochemical details, just to tell you that when you give opiates, you do not see the tolerance. Actually, it's rather the opposite. And this is very important because, for example, if you give opiates for pain, you see a deterioration, a slowing of the effect over time, whereas the constipation seems to build up over time. And if you use opiate tincture or dropizole for treatment, you should also expect an increasing effect on the colon over time. But we do not have any studies that can show that for sure yet. So now these were the preclinical studies. Then what about man? Well, we know that if we give opiates to the patients, they do not only suffer from constipation, but also the first symptom they experience is the dry mouth, and then comes the nausea, the heartburn, the reflex, and maybe the vomiting. And later on, they complain about abdominal distension, gas and bloating, straining, incomplete defecation, and especially infrequent bowel movements. And these side effects are actually effects that we want when we treat diarrhea, but effects that we do not want when we treat pain, because then we have problems with constipation as a side effect. To the right side, you can just see some of the papers we published about that in our group. So the way we assess opiates effects in humans is that we ask different questionnaires. And I'll not use a lot of time on that, just tell you that mainly when we ask about the effect of opiates, we use the PAC-SIM, which is a symptom, where we rate the symptoms on a Likert scale. We can also use the PAC quality of life, and finally we have specific questionnaires for opiate-induced constipation. One questionnaire that we use a lot, and you likely know that all of you, is the Bristol stool chart, where patients assess not only the number of bowel movements per day, but also the consistency of the stools. And this is something which we call semi-objective, because it's not only a matter of how they feel, but they can also directly report the consistency of the stools. And this is something I recommend you to use if you should use opiate tincture for diarrhea, because it's very easy for the patients to use and you get a lot of information from it. Now, what do we then know about acute versus chronic effects of opiates? We have done some studies, you can see them listed down here, where we ask systematically healthy volunteers about which symptoms they develop over time when we give them opiates. And what we see is that in the beginning they complain about the acute effects on the upper abdomen, that is the vomiting, that is the nausea, abdominal distension, but over time they complain mainly about constipation, say typically after 3-4 days. So that again shows that this effect, this tolerance in the colon, you simply do not see. And therefore, again, coming back to the opium tincture, it seems, at least based on the studies we have done in morphine and also in oxycodone, that the effects on the colon are present over a very long time. Moving from the subjective measures to the more objective measures and how opiates interfere with the gut. First of all, I want to stress, and I'll come back to that patient studies are very difficult when it comes to the study of very detailed opiate mechanisms, because patients do not only have constipation, they have a variety of other symptoms because they're patients. So typically they also have incontinence, psychological factors, social consequences, and so on. And all these different symptoms, they are all related. And it makes it very difficult to study constipation alone, because there are so many other symptoms that interferes with the constipation. And therefore, what we do, and what I will show you mainly here, is that we actually induce constipation in healthy volunteers, and then we assess very detailed the evoked responses. And having done that, both subjective and objective, I should say, and having done that, we can study different drugs in the model. So the advantage here is that we can really control the situation because these are healthy. They do not suffer from any concomitant diseases or disorders, and they do what we tell them to do. But the downside of such a model is, of course, that they are not patients. So there are many things that differ. Typically, they're younger and so on. But the detailed mechanisms of opioids we can study in a very good way. Now, when we assess constipation objectively, we have a variety of methods in the clinic. The problem is that there is no consensus on which method to use, and furthermore, there is a very limited relationship between the findings from objective experiments to symptoms. So this is typically a downside. What we do is that we use more advanced methods when we assess colonic motility. We want to see exactly how the feces is moved and how much the force and contraction and so on is on the different segments in the gut. And the way we do that is an experimental method we use, where you have different magnetic capsules, and then you have a sensor here that the patients wear in the ambulatory settings, so you can at every second measure exactly where this little capsule is in the gastrointestinal tract. This is a system only for research purposes. You cannot just buy it, and it's a bit cumbersome to use, but we have done a lot of studies in healthy volunteers and in patient groups. And this is typically a tracing. You can see how the capsule moves in the colon in one of our volunteers here. So you measure the locations and the rotations, and also thereby whenever there is a contraction, the capsule rotates, and that you can measure. Sorry. So just to show you how it can work, in an experiment, we took 25 healthy volunteers and we gave them, so to say, constipation by giving them oxycodone. And what you can see here, this is bowel function index. You can see placebo gave no constipation, whereas the oxycodone gave very much constipation. But we don't know anything about, they can just complain about constipation. But when we use the capsule, we can see that the constipation is present mainly in the ascending colon and then in the rectosigmoid colon. So that means something, because then we know where to target the disease and which medication to use. We can also do more detailed study, and now this is the center line, the blue one here, the curve here on the right side shows the same, but the blue line here shows the center line from an MR scan of one of my postdocs. And so we know how the colon looks like. And then he swallowed the capsule. This is a little green spot that you can't hardly see. And then we have this red circle. It shows where the capsule is in this center line. The little blue spot shows where the capsule moves. What I want to show you now is how the capsule moves from the cecum to the rectum, and what you believe, of course, if you don't know much about motility, you should expect that the feces moves slowly to the rectum, where it's stored, and when convenient, people go to the toilet. But this is not the case. Now I'll show you a movie. You can see how it moves. You can see it moves forth and back, then it goes to the right flexure, where it stays for a rather long period. But sooner or later, you can see that the capsule moves suddenly fast throughout the transverse colon, but also again a bit retrograde, forth and back to the left curvature, but then back again to the right left curvature, and then down to the rectosigmoid, where it moves forth and back, and then it comes to the rectum, but it goes back again, as you can see. So the thing is that capsule movements and fecal content is not just moved from one end to the other, but it has a certain pattern. And the fast movements, which you can see here, they are the determinants for the propulsive activity. This is what means something. There are some small movements here and there, doesn't mean much, but the fast movements, this is where the capsule really works or moves, and this is the most important. You can use this to look into very detailed and individual human data, especially looking into these fast contractions. And this is a study where we gave oxycodone and we compared with placebo, and the green arrows here shows the movements, and what oxycodone did was that it reduced the length of the fast movements, but also the number of the fast movements. This is what happens, and this is already very important to understand the effect of opiates on the gut in such a very detailed study. So now moving from secretion to from motility to secretion, it's very important again to stress that opiates, normally there is a balance between the absorption of fluid and the secretion of fluid that gives normal stools. But when you give opiates, there is a fast absorption and nearly no secretion, and that results in dry, hard stools that are very difficult to defecate. It's like cement. But of course, again, if you have diarrhea and you want to treat with opiate tincture, you should be aware that that could actually be very good effect, because diarrhea, as you know, is flushy, watery, and you want to increase the consistency of the stools, and this is something you can do with opiates, even though we do not have any detailed studies yet about how opiates work in diarrhea. What we do is that normally we assess the iron flux over the mucosa, because if you have normally chloride ions are secreted out of the mucosa, and then together with them follows water. And one way to do that, is to use a so-called Ossing chamber. We did a study some years ago, but we didn't find much changes in the colon, likely because most of the fluid is absorbed in the small intestine. So another way to do that is to quantify the fecal content in the colon, and this is what we do. And the way we do that is, as many of you will likely remember, in the beginning we had I showed you that we had a lot of imaging studies ongoing. And what we do is that we take an MR scan, and then we segment the colon semi-automatically. As you can see, we published that 5 years ago, and then we get such a picture of the colonic content, and then we can assess how much is solid, how much is fluid, and how much is air. So now, to show you how it works, this is again volunteers. We gave them placebo over 5 days, and the different colors thus displays the different segments of the gut. And what you can see is that when we give them placebo, there are basically no changes in the different segments. But when we gave them oxycodone, the picture totally changes. What you can see is after 5 days there is an increase here in the ascending colon, and also an increase of feces in the rectosigmoid colon, which is expected. But what we did not know was that there is an increase especially in the ascending colon, which is very difficult to treat when it comes to constipation. And the reason for that is it seems as though opiates block the pacemaker for the so-called mass movements, those that are illustrated for you before, they're very important for motility. And if the pacemaker is blocked, the fecal content seems to store up here in the right colon. And so we know again much more about the detailed mechanisms of opiates on the gut using such models. Another advantage of the MR models is that we can actually assess the degree of water. And in another study published a couple of years ago, first we did some phantom models with oatmeal mixed with water, and were able to extract the information of how much fluid there was. And then we took it into a study with oxycodone versus placebo, and we were able to see that oxycodone gave much drier feces. And we also recently showed that in 2 studies we published this year, where we compared oxycodone with tapentadol and placebo, and were able to see the same. So when it comes to the small intestine, we have different models running, and I'll not give the details now because we're working with it right now, but they are really promising. We are able in the small intestine to measure motility indirectly, and we're also able to measure the water content. And we believe that when we give opioids, we can see changes, but that has not yet been published. So one final thing that is very important is the efficacy on opioids on the sphincters. And what you know is a sphincter like the sphincter of Oddi here has been very much studied, because we know that when we give opioids, we see an increased number of gallstone attacks because of contraction of the sphincter. When it comes to opioids, we're actually more interested in another sphincter, namely the rectal sphincter. And the way we study that is by using the recto-anal inhibitory reflex. And again, I'll not bother you with all the details, but just shortly tell you that what we do is that we inflate a bag here in the rectum, and opioids only have an effect on the internal sphincter, not on the external sphincter. And the way we can measure the effect on the internal sphincter is that normally when you inflate the balloon, the sphincter should relax sooner or later. And then you feel like you want to go to the toilet, but you still have the external sphincter, so you don't get incontinent. But the internal sphincter should work. And the way we measure that is when we inflate the balloon, we see such a dilatation of the sphincter pressure, as illustrated here with the red arrow. But when we give opioids, you typically see this, and we published this in a couple of studies. When you give opioids, you do not see any relaxation anymore. I mean, for the patient, it means the patients in opioid therapy for pain, they typically complain about sensation of anal blockage. They strain often, they have hard stools. And again, if you have diarrhea, this may be an advantage. You can actually seem to control the internal sphincter a bit more, because many of those patients, what they complain about is incontinence. And fecal incontinence has a major social impact, because they cannot go to the supermarket, they cannot go nowhere because they're so afraid of incontinence. I'm often asked this question, this is why I take it up. Are there differences due to different types of opioids when it comes to the effect on the bowel? And this study is shown here, there are no differences at all. And I'll also say that if you give strong morphine or you give weak opioids such as tramadol, for example, you see no differences in the opioid-induced bowel dysfunction. All the symptoms here are exactly the same for the strong opioids and the weak opioids. So it doesn't matter. And actually, opiate tincture is very weak. It corresponds to very low dosages when you convert them to morphine. But you should expect to have many of the same findings. Yeah. So just to sum up, please remember that opiates interfere with motility, but it's not only motility as many doctors think. It also interferes with secretion, giving hard stools, and finally it interferes with the sphincter function, so it can give straining problems, but also it can be helpful in diarrhea. Yeah. Now, what about opium effects? I put a lot of question marks there because we know a lot about the effect of morphine, oxycodone, and classical mu agonist. But opium is a drug that has a lot of different components, as you can see here. There is some morphine in, there is codeine in, thebaine, paraverine, muscarine, and so on. And actually there are likely some other substances that we don't know. So it is what we normally call a dirty drug. it has a lot of substances. On the other hand, it can be very helpful because it has all these substances. But we do not know anything about how opiates work on the gut, opium work on the gut. So opium tincture, we have used it for hundreds of years, but we really do not know anything about the detailed mechanisms. From here, and please think about some questions and some discussions that we could have, and as I said before, you're welcome to ask them in Portuguese and we can translate and then back translate maybe.
For sure.
So moving on to management of diarrhea and opioids. You should be aware that when we define chronic diarrhea, typically we claim the patient should have, that the fecal weight should be above 250 grams for more than 2 or 4 weeks. The problem is that it's very difficult to persuade patients to weight their feces. So in clinical practice, we typically say that, well, if you have more than 3 bowel movements daily and if it's very watery, then you have diarrhea. The prevalence of chronic diarrhea is actually huge. In US, we have numbers up to 5%. And when you use a more loose definition, such as the one with more than 3 bowel movements per day, is up to 15-18%. But many of those patients have irritable bowel syndrome. But no matter what, it is a very prevalent disorder, and there is still a need for us gastroenterologists. I'm not speak about the mechanisms and the different pathophysiology behind diarrhea, just to again tell you that we normally subdivide diarrhea into either watery diarrhea, inflammatory diarrhea, or fatty diarrhea. And the most frequent reasons, at least in Europe, for diarrhea is irritable bowel syndrome, and then we have diarrhea with inflammation, typically inflammatory bowel diseases. We also have some infectious diarrhea such as Giardia, Clostridium, or Clostridoides as it is now, infections. We have lactose intolerance in some countries. For example, in Finland, up to 90% of the population have lactose intolerance. Pancreatic insufficiency, giving fatty diarrhea, is also seen. It's not only patients with chronic and acute pancreatitis, but also a lot of other diseases such as celiac disease, which you can see later down, gives pancreatic insufficiency. Microscopic colitis is a combination of collagenous colitis and lymphocytis colitis, and this is also very prevalent, especially in the elderly. Then you have bile acid malabsorption, you have bacterial overgrowth, different medications that can diarrhea, and finally patients with diabetes. So these are the most frequent reasons, but there are many other reasons for diarrhea. Many of those can be treated by treating, for example, the celiac disease or the lactose intolerance, but many other we do not have any treatment but symptomatic treatment. This is where Dropizole or opiate tincture comes into the picture. And when we look into opiates and diarrhea and how to manage it, it changed a lot according to different papers and textbooks. This is a guidance in the management of diarrhea during cancer chemotherapy. And I know it's very small and you're not supposed to read it. It's just they came up with different recommendations, but none of them were opiates. And this is actually the flow chart I made, and I need my glasses here, because I can see that normally they recommend to use loperamide, which is recommended all over the world. But if it doesn't work, they consider quinolones and octreotide, but stronger opiates are not on the flow chart at all. Then you can see this is a very busy slide showing the different recommendations from another paper from systematic treatment. And what you will see here that the only opiate that we see is loperamide again. So in many textbooks and many recommendations and guidelines, they do not even mention that we also have stronger opiates. This is another recent review that also recommended to treat persistent diarrhea with loperamide and avoid antibiotics. And finally here, If it doesn't work, again, only loperamide or octreotide were mentioned. But this is another picture we see, at least in our clinic. This review here shows the pharmacological agents for chronic diarrhea. And here what you see is that now the only opiate that they mention again is loperamide. So in many of these recommendations textbooks, they only mention loperamide, which is a classical opioid that is not supposed to cross a blood-brain barrier, but I'll come back to that. Now, coming back to textbooks, you can see now we see opium tincture as one recommendation to treat chronic diarrhea. And you can see that they recommend different medications such as loperamide, codeine, morphine, and opiate tincture, and then a lot of other substances that are more difficult to use. And our approach in Denmark in the Department of Gastroenterology is that we normally try to give them some bulk to give the feces a more firm consistency using psyllium with calcium carbonate, but I think this is only used in Scandinavia. Otherwise, like all over the world, we recommend to use loperamide, typically 2 milligrams 3 times daily or more. We also sometimes use resicapril, which is a medication that actually induces the endogenous opioids. So rather than giving an opioid, we give a drug that increases the concentration of endogenous opioids on the gut. But we don't use it much, I should say. So typically when loperamide doesn't work, we switch them to codeine. We call it strong codeine, which is 8 milligrams per liter. We give 10 milliliters 3 times daily or increase that. And finally, we can use opium tincture if it doesn't work, and this is a typical recommendation for that. Typically, we start with 5 to 10 droplets twice daily, but we can use up to 20 droplets, maybe 30, 3 times daily. And finally, we also add on proton pump inhibitors and sandostatin or octreotide in case needed. So this is our typical approach. The problem is that it has always been claimed that loperamide doesn't cross the blood-brain barrier, and therefore it is safe to use, and it is also over-the-counter in most pharmacies around Europe and US. But if you look into the literature, actually, you can see that this about opioids cannot cross the blood-brain barrier dates back to 1978, where they were able to show that loperamide concentrations were much higher in the peripheral blood as compared to the brain. But the study showed here is a case story actually with a 42-year-old man that was found unconscious in cardiac arrest after having taken loperamide. And you should be aware that the symptoms and signs of opiate overdose is a classical reduced level of consciousness, swallowed breathing, maybe respiratory depression, and then these pinpoint pupils. And then you can see cardiac arrhythms such as prolonged QT and also tachycardia such as torsion de pointes and then cardiac arrest. And you can also see acute pancreatitis as seen in this case. So even loperamide can be very dangerous to use, and no matter what opiate you use, you should be aware that it can actually be risky business, including opiate droplets. The problem, as I have told you many times, is that we do not have any evidence for treatment of diarrhea with opium. This is just something we have done for several hundred years with good clinical evidence, but we want to know more about the effects of opiates on the gut. So in collaboration with you, we have started 2 studies. One study to look into the efficacy and side effects of opiate tincture in healthy subjects, and the second study to look into the efficacy and side effects in patients with different kinds of diarrhea. It has, due to the COVID pandemic, it has been very difficult to start up the study because all the regulatory resources, legal resources, and so on have been used for the different COVID studies, and therefore we have really been 1 year delayed, but we are up running now, and we have included the first 10 volunteers. Just before I show you the detail about the studies, I just again want to stress that you should be aware that there are many limitations in clinical studies. One example here is that if you measure the blood pressure or some hardcore parameters like blood sugar and so on, you can be rather sure that you have the right baseline. And when you then do a kind of treatment and you see an effect, it will very much likely be due to the medication. The problem when you have constipation, diarrhea, but also other symptoms, very subjective symptoms such as quality of life, anxiety, and pain, your baseline is very fluctuating because it changes a lot. And when it comes to diarrhea and life quality and so on, there are fluctuations over the journal fluctuations, but there are also many other changes depending on stress and other medications and so on. So it's very much less well defined. So when you give a treatment, you really don't know whether this is a real effect or whether it is by chance. And this is one of the problems we have we see in the clinical studies. Another way to show you such an randomized controlled trial is that if you want to study constipation, in this case, could also be diarrhea, an effect on the gut, you should also be aware that there are many other effects that your medication will typically work on, and there are also many side effects. So now, if you take the medication here illustrated with the blue line, it could be a kind of drug that has an effect on motility, but it could also have sedative effects, anxiolytic effects, and so on. Because you should be aware that drugs such as opioids, they have many effects. It's not only the effect on pain or the effect on motility, they have a variety of effects on the whole body. So now you give the medication and you have an effect, for example, on the constipation, or I should have written diarrhea, but nevertheless, there are also an effect on many on the other symptoms, such as sleep better, there is less CNS effects and so on, and you have a lot of side effects, and all these are related. So typically you end up in studies with hundreds of patients, complicated statistical models, and still equivocal results. So again, I'm not saying that we should not do clinical studies. We should just be aware that they are very difficult to interpret because of all these different confounders. So the alternative is experimental studies, as I showed you before, where you give a controlled induction with opiates in healthy volunteer, you give them constipation, and you assess the evoked response. It will never be the same as clinical studies, but you extract a lot more detailed data about the efficacy of your medication. And it can also normally be translated directly to the clinical studies in patients. So now the first study we're doing is the one with 20 healthy volunteers, where the first 10 are recruited. And what we do is that we study them first with opiate tincture, 10 drops 3 times daily, or placebo. Then we cross over and then have either opiate droplets or placebo. And what we do is that we measure here the 3D transits, the very detailed motility assessment, as I showed you before. We do that also at the end of the study. We do another study. I have not showed you the details here. We do MR. It's not only MR scans of the colon, but we do what we call the pan-intestinal model, where we assess the motility of the stomach and the stomach emptying and deformation, all that stuff in the stomach. We assess the small intestine and we assess the colon. All in one experiment takes about 90 minutes. We do that before and after the study. And again, it's something you can only do in healthy volunteers. It's very difficult to do in patients because they're long-lasting and a bit cumbersome and can also be unpleasant to get done. But if you pay the volunteers right, we can also get the studies done. And then, of course, we assess a lot of questionnaires, how they feel, how much constipation they develop, and so on. And in order to look into side effects, we measure the pupil reaction, the reaction time, and different questionnaires. So this is the way we do it, and the primary endpoint is the transit time in the different segments as measured with the 3D transit. And then we have a lot of secondary endpoints, and you're likely not very much interested in that. The second study is a study in 40 patients with diarrhea. This is a parallel design study where we taper them up. So we start them with 3 droplets 3 times daily, and then we give them 5 droplets, 7 droplets, and finally 10 droplets, drops 3 times daily. And again, like before, we assess the 3D transit, the very detailed motility measures before and after the study. We give them some questionnaires and we look into the side effects, but we don't use the MR model because this is a 2-center study and the MR study can only be done in Aalborg because this is very advanced and we have our own 3 Tesla scanner to play around with, and that can only be done with us. And the primary endpoint here is then the change in the bowel movements. This is a clinical endpoint, whereas the secondary endpoint is the 3D transit and also the side effects. So this was my last slide. I'll stop sharing. So just to repeat, first of all, I told you a bit about our research group. Then I showed you how opioids interfere in the gut, how they feel the different mechanisms in the gut, and remember that they change motility, they change the water composition of the feces, and finally they change the sphincter function. And then lastly, I showed you the traditional management of diarrhea and the studies we have ongoing in order to explore the efficacy of Dropizole or opiate tincture in the different segments of the gut, both in healthy volunteers and in different patients with chronic diarrhea. So thank you very much for listening to me.
Thank you very much, Professor, for your amazing presentation. We have several questions now. Okay. I think it's better for the audience also to receive your feedback directly. If I can read some of the questions. Okay, I will start from the first one received from Florbella Braga. Okay, and the question is, within your clinical practice of use of Dropizole tincture, Dropizole, okay, if you have many adverse effects of use of this kind of product or not, and in case you have, if those adverse events are easy or not to be reverted back. Okay,
thank you very much for an excellent question. Well, in our clinic we use Dropizole mainly for, of course, patients with refractory diarrhea, and we see a very good effect of it, but of course we see side effects. In the beginning of the management, we typically see dizziness and it could also be a bit nausea, but mainly the central nervous system side effects. But they seem to disappear over time, and if you remember my slide about tachyphylaxis, it seems as though the effects on the brain vanish over time. Patients are always very afraid that they cannot drive when they receive opiates and so on, but from a clinical viewpoint, it doesn't seem to be a problem with sedation after a treatment of up to 1 week. Of course, we have patients that develop addiction. I should say we have very few, but we have seen some cases where they simply take the full bottle and then they swallow everything. But these patients are patients that we know already beforehand. They are very prone to become addicted. They use a lot of different medications and drugs and buy everything on the black market, and this is very difficult to control no matter what. In general, most of the patients we don't see addiction and tolerance to the effects on the diarrhea is not a problem, whereas the central nervous system side effects seems to vanish over time.
Thank you very much, Professor. I don't know if Florbella has any doubt.
I should also, sorry, just have another comment. I mean, you should also be aware that this opiate tincture has been used for many hundred years, and it's really a safe drug to use.
Okay.
But always when it comes to opiates, you shall be careful to monitor the side effects, and also it may also be very harmful in selected patients.
Okay.
Thank you.
Now, a second question from Sandra Cantrapona. The question is if you have some knowledge about any case of overdose.
Well, I mean, in my personal experience, we have never seen overdose to opiate tincture. We have seen overdose problems with a lot of other opioid medications, for sure, or narcotics. This is unfortunately rather frequently seen, but it doesn't seem the problem is not as big as it is in US, where they have kind of opium phobia because that they are so afraid of overdose problems. We don't see it, and again, if you translate the dosages we use for treatment of diarrhea up to 20, normally up to 10, but could be 20 droplets 3 times daily. This corresponds only to, I don't know for sure, but about 20 milligrams of morphine, and this is nothing. So they really had to take several bottles a day in order to get to really get any lethal overdose. So in general, no, we don't see it. When we see overdose problems, it's typically when they use opiate droplets or tincture together with other opiates.
Okay. Another question is not on the overdose, but on the constipation. Do you have any occurrence of constipation?
Oh yeah, sure. That's what we want to have. If you can, I mean, but of course, I mean, if you have, I mean, say if you have a patient that have diarrhea 10 times a day and you give them opiate tincture, and they come after 1 week and complain about constipation, you have to taper them down. I mean, so we see that, but I can't remember the last patient with constipation. We have seen it, but it's very seldom because normally we give them only. We give them, say, I mean, tincture in a dose, so they go from toilet visits 10 times daily to maybe 2 or 3 times daily. So in practice, we don't see it, but of course, it can give constipation. And in the healthy volunteers, where we give opiate droplets, we actually want to induce constipation to see the effects on the medication and the gut.
Okay. Another question is regarding if the opium tincture provokes any kind of coloration in the intestinal mucosa.
That's a good question. Also, that we don't know. But we know that opiates seems to change the microbiota because it changes motility and therefore the normal colonization. We know from other opiates that they do, but we don't know exactly how it works. We have done some studies ourselves, which is not published, where we look into the effects of opiates on the microbiota and their metabolites. So for sure that we expect something to happen with opiate tincture as well. But as I said, we have no studies at all in the efficacy of opiate tincture on the simple mechanisms of the drug and not on the microbiota at all. But there is something for other opiates, so we should expect that. But what it means, if it means anything, we don't know.
Okay. The question related to this one if it can mask or not any kind of lesions about this coloring action in case it happens.
No, I don't think so. I mean, in general, when you give opiates, it doesn't change the diagnosis. It doesn't change anything. I mean, previously in acute abdomen, opiates were not given because clinicians were afraid that they could mask different symptoms. But a lot of good studies, including the review by Falk and co-workers 4 years ago, where they did a meta-analysis of all studies where they gave opiates to acute abdominal pain, it did not mask anything. So I don't think it would happen to opiate tincture. Again, it is very low dosages.
Okay, good. I don't know if the Sandra is happy with the questions. Okay. Otherwise, I can pass to the next one. And in case she's not happy, I would ask her to get back with any kind of outcome. Okay. Sure. Next question is there any experience with short bowel syndrome?
Oh yeah, that is actually where we use opiate tincture the most. We have a unit in my hospital with referral from most of Denmark with patients with short bowel syndrome, and this is actually where we give opiate tincture most, where it seems to be very efficient there as well.
Okay, good. Passing for the next one, do you have any experience in bone marrow transplantation patients with digestive growth versus host disease situations?
Nope, I must say. We know that these patients may develop diarrhea, but I have no experience with that. No, I can't tell. I don't think because normally we use opiate tincture only for long-lasting diarrhea. Typically, the patients are referred to us and they've had diarrhea for several months, and this is where we have used it. But in the more acute phases, I mean, I would never use opiate tincture for acute diarrhea. And with bone marrow transplantation, I don't think it lasts that long, but I'm not that experienced with that. But I cannot recall any patient, and I don't think it should be used there.
Okay. Next question. From a doctor's perspective, what is the top 3 reasons for using opium tincture for patients with severe diarrhea?
Well, it's difficult to say what is the top 3 because I'd rather say we use this pyramid. If we have chronic diarrhea and we cannot treat it causally, I mean for the mechanism based, then we typically start with loperamide. We give also this Danish prescription of psyllium, but then you could say that number 3, should that be codeine or should it be opiate tincture? I cannot really see any reason why we should give them codeine. It's just by tradition. You should know that all that we give, these different medications we give for diarrhea, this is not evidence-based. This is based only by doctors' experience. And it changes a lot from country to country. But what we do is that we start with a very weak opiate. We believe that loperamide is not that toxic or expensive, but again, please be aware that it can be. And then we add different opiates, starting with codeine, moving on to opiate tincture. But I think we need more randomized control studies in order to explore that. I'm not sure if it was the right answer, but I can't find. I can't see what else I should answer. What else I should say.
Another question is regarding loperamide. When and or how fast should you change to opium tincture in the cases that it is not?
Okay, that will be very individualized. If you have a patient refractory to loperamide, as I said, typically what we do is that we taper it up and down, but then next step in my country is typically codeine, and after that opiate tincture. But I think it has to be really individualized. It's very difficult to say, to make a very simple flow chart, because in some patients we could add octreotide. Some other patients we could give them a PPI, or we could see how much it really means for them. So it differs a lot from patient to patient, and I don't think I can give you a very strict recommendation that fits into your country. But for sure, I think if you have a patient refractory to loperamide, you should try something else where opiate tincture is one of them. And if it has if it's very effective, I also think you should try to taper it down after typically 1-2 months, because chronic diarrhea also changes over time, and even though the patients benefit from opiate tincture, they may not use it, it may not be needed, sorry, for more than a few months. So you should really monitor your patients properly and then consider whether or not to continue the use.
Okay. I think the next question is specifically regarding this in terms of patients. Okay, in what patients' characteristics from your experience predict a positive outcome of the use of opium tincture?
Okay. Speak about personalized medicine in this case. This is something where I don't have the sufficient experience with it, so I simply cannot tell. I think most of US doctors will know already beforehand, because, I mean, my nose will tell me very early in the consultation whether or not this patient will be easy to treat or not, and whether or not the diarrhea is really a big problem, or whether or not the patient just say is very subjective in their expression of the disease. So I think we do not have any evidence that can tell us who we should expect to end up with opiate tincture. Not to my knowledge.
Okay, thank you very much. I think that you have already talked about addiction, okay,
yeah,
regarding the opium tincture, but
I can repeat that. I mean,
yes,
it happens. We have seen some patients, and these are specifically patients with short bowel syndrome, that receives a lot of opiate tincture, but also other opiates. So I have never seen addiction to opiate tincture alone. It's always kind of mixed addiction, and as you can likely understand, many of those patients with short bowel syndrome, they suffer from a lot of other diseases, have a lot of abdominal complaints and pain for many reasons. So they're really difficult patients to treat, and they are really a high risk group for addiction in general.
thank you very much. Next question, Professor, regarding if you recommend or not to use concomitantly with the opium tincture probiotic, for example.
No, we don't have any evidence for the efficacy of probiotics in diarrhea, but of course we see selected patients with an effect, but we don't recommend it, not at all. But it would be wise. Normally we use such kind of lifestyle guidance for those patients. Typically, when you have constipation, for example, you advise them to have more exercise, more fluid. When we have patients with severe diarrhea, we guide them not to have more exercise, but we still guide them to have less fluid intake, and such more general recommendations can be used. And probiotics, well, in some cases it may be useful, but we do not have any evidence for it, and we never use it. And we don't use it always together with the opiate tincture. No.
Thank you very much. So next question from Patricia Cavaco. Patricia, thank you. Would like to thank you for the excellent presentation. Okay, in relation to drug-drug interaction, did you explore it in your study?
No. I mean, the two studies we're doing, the first one is in healthy controls, because they only receive opiate tincture. And it's a very good question, because the second study, where we use patients, we exclude those where we can potentially have a drug-drug interaction with opiate tincture. And that has actually been a problem because we haven't enrolled many patients yet. And the main problem is that they have suffered from many other diseases that are exclusion criteria. We are not that afraid of other drugs interfering with opiates, but many of the patients unfortunately get morphine or other opiates for pain at the same time. So it can be problematic.
Okay, yeah, I think it's related there. Should we expect the same time of interactions of the other opioids in this case?
Yes, for sure. In some of the recommendations that you actually that I showed you, for example, morphine was recommended to treat diarrhea. And I would say, why not? Because it would bind to the opiate receptors in the gut. The reason we use opiate tincture rather than morphine or oxycodone or whatever is that we have long-lasting clinical experience, and it may also be that the many different opiates that we have in the opiate tincture are more efficient when they go together, but we don't know much about it. It's just my personal feeling. But in theory, all opiates should have the same effect on the drug, but on the gut. But it may be that the tincture, due to the droplet consistency and the many opiates, are better. At least the clinical evidence for many hundred years have shown us that it is very effective.
Thank you very much, Professor. I don't know if the audience has any kind of additional questions. At this moment, I have no additional questions raised, either by chat or by email.
But I think we also had a very good discussion, and I want to thank you all out there for these questions. They were really good, and it's always nice for me also to be challenged a bit, also from a clinical perspective, because this is not an easy task, not even for a gastroenterologist, and it is difficult to treat chronic diarrhea. But the thing is that we have a lot of medications in our armamentarium, and I think we should use them all, including opiate tincture.
Thank you very much, Professor. So I would pass the words to Carlos to close the webinar.
Thank you very much, August. First of all, as president of Biogem, it's a big pleasure and an honor to receive a lecture from Professor Asbjørn as a key opinion leader, an important key opinion leader in this field. Thank you very much. Amazing lecture. I take also this opportunity to thank to all participants. And of course, if you have in the future some, if you needed some answers about some doubts you have it, please don't hesitate to contact Biogem through our employees. Of course, I need to thank also to Pharmanovia partners. Without you, it's not possible to make this amazing lecture. For that reason, thank you very much. And the last but not the least, all of this seminar is not possible without the hard work of the Biogem employees. And this is my last thank to you, because without you, it not be possible to do it. I hope you have a nice evening. For us, a nice dinner. For Professor, I know you dinner at 6 o'clock. But please have a nice evening. Thank you very much for everything. And Biogem is always open for you. Thank you.
Thank you very much.
Thank you very much.